Most important disease of retina, that is retinoblastoma. This is the most common ocular tumor of the childhood. Please remember, this is a question very frequently asked. Most common ocular tumor of childhood is retinoblastoma. And the commonest age of presentation is 18 months. You have to remember this as well. At 1.5 years of age, most of the children will present to you with a retinoblastoma. Okay, 40% of the cases are hereditary. This can also be a question. 60% are sporadic. However, 40% are hereditary. Now, the mutation takes place in all the cells of the germline. Hence, it is known as germline retinoblastoma. So, another term used for retinoblastoma, that is the germline retinoblastoma. Whenever it is bilateral and multifocal, however, there is an earlier presentation. When we come to laterality, only 30% of retinoblastoma cases are bilateral and 70% are unilateral. So, whenever there is bilaterality, we can understand that the presentation is earlier. We have seen that 60% are non-hereditary and they occur when the mutation takes place in the somatic cells. Okay, these non-hereditary type of retinoblastoma is usually unilateral and has a very much later presentation compared to our hereditary type. Okay, now look at this mass growing through the retina. This is our retinoblastoma. Okay, let's look at the genetics. The most famous gene in this is our RB1 gene. This is the first tumor suppressor gene ever to be discovered. This is a tumor suppressor gene, and where is it located? It is located on the 13q14 of, that is the long arm of 13 chromosome on the 14th band of the chromosome. Okay, now by Q I mean long, by P we know petit means small. So 13q means on the long arm of the 13th chromosome, that is this one, on the 14th band is located our RB1 gene. Please remember this. And this follows the KNUDSON'S 2-hit hypothesis. Okay, the KNUDSON'S 2-hit hypothesis says that there need to occur two hits for the mutation to take place in the RB gene, for the tumor suppressor gene to convert into a tumor causing gene. The KNUDSON'S 2-hit hypothesis says that it needs to occur in 2 steps. Okay, now let's go to the clinical features. The most striking feature and the most important feature is our Leucocoria. It's nothing but the Amaurotic cat's eye pupil. By Amaurotic I mean blind. It looks like a blind cat's eye. Okay, this is a white pupil. What you're seeing here, this is our Leucocoria or a white fundal reflex. Now the second most common presenting feature is strabismus. There is a squinting of the eye because of the lack of usage, because the retinoblastoma is blocking the visual axis. So that eye is not being used, hence it becomes a squinting eye. Okay, the third most common presentation is our neovascular glaucoma. Please remember all of these. Leucocoria is number 1, followed by strabismus and then neovascular glaucoma. Then the third most common feature here can also sometimes be a pseudohypopyon. We know that hypopyon means pus in the anterior chamber. Now I am calling it pseudohypopyon because this is not pus, but it is a collection of the tumor cells in the anterior chamber. So pseudohypopyon is also a presenting feature in retinoblastoma. Now some other features that can be as the presenting features are loss of vision, heterochromia, that is 2 differently colored eyes, then hyphema and uniocular mydriasis. Hyphema I mean blood in the anterior chamber, and uniocular mydriasis is nothing but one pupil is dilated and the other is normal. This is a dangerous sign when you see it in a child. Now let's look a few questions that are important for our exam. The differential diagnosis of leucocoria. Leucocoria always does not indicate a retinoblastoma. Sometimes it can occur due to a congenital cataract or a persistent hypoplastic primary vitreous. Now, this is very difficult to differentiate from retinoblastoma. Now let's try to understand what is this persistent hyperplastic primary vitreous. We know that vitreous occurs in 3 stages while it's forming in the fetus. The primary vitreous, after the baby is born, it disappears completely. Because it is vascular, it disappears because we need a clear visual access. However, if it persists, that condition is known as our persistent hyperplastic primary vitreous, and it will result in leucocoria or a white fundal reflex. Now the secondary vitreous is the normal vitreous that is present in our eye, and the tertiary vitreous is converted into zonules. Please try to remember, the tertiary vitreous is converted into zonules. Now, how will you differentiate persistent hyperplastic primary vitreous from retinoblastoma is that PHPV is always unilateral and is only seen in a microphthalmic condition. Whenever the eye is very small, that state you have to suspect PHPV and not a retinoblastoma. The next condition causing a leucocoria is Coats disease. Now, Coats disease is seen in boys in their first decade of life. This boy that you're seeing is having Coats disease, and you see it in young boys. Boys wear coats. Okay, that's how you can remember. The other causes of leucocoria are retinopathy of prematurity, toxocariasis, endophthalmitis, retinal detachment, Norris disease, and coloboma. Okay. Let's come to the diagnosis of retinoblastoma. It is primarily a clinical diagnosis. We have seen how the fundus appears with a white pupillary reflex. However, if you want to go for imaging to support your diagnosis, the characteristic intraocular calcification should always make you think about retinoblastoma. What you're seeing here is an intraocular calcification. This calcification is occurring within the tumor body itself, and you should confirm that it is a retinoblastoma. Now on histopathology, this is an important exam bit. This is a hallmark of retinoblastoma is your Flexner Wintersteiner rosette. What is it? The Flexner Wintersteiner rosette. Another type of histopathological feature is of a Homer white rosettes as well. Homer white rosettes. These are also present in retinoblastoma. However, Flexner Wintersteiner are the hallmark of retinoblastoma. Okay. Now you have diagnosed your retinoblastoma. What will be your course of action? The first and most important thing that you have to do, because it is a cancer, it's a tumor, your primary aim will be to save the life of the patient. First, you have to think how will you salvage the life of the patient. Then your secondary aim is to save the eye. You should try not to enucleate the eye as much as possible with conservative management. And then your third and last aim will be to safeguard the vision. So the first important thing you will do is to save the life. Now, for the treatment, there is a classification of retinoblastoma, that is the ICRB, that is International Classification of Retinoblastoma. It's a very simple classification. Stage A, where the size of the tumor is less than 3 mm, it has a very good prognosis. Stage B is where this tumor is greater than 3 millimeters in size. The prognosis is not good, and if it is very bad when it is in a macular location along with subretinal fluid. Now, stage C comes to localize the seeds within 3 millimeters. That is, the tumor has started spreading over here. It has a moderate prognosis. The seeds can be located in the subretinal space or within the vitreous. The tumor is seeding into the eye within the vitreous or in the subretinal space, that is anteriorly or posteriorly. Now stage D is when there are many diffuse seeding of the tumor is seen with more than 3 mm in size anteriorly or posteriorly. It will definitely have an unfavorable prognosis, and our stage E is a massive retinoblastoma where more than 50% of the eyeball is involved along with a secondary glaucoma, hemorrhage and extension into the optic nerve. Now this is a very aggressive form of retinoblastoma and will have a grave prognosis. So stage A is less than 3 mm, good prognosis. Stage B greater than 3 mm has not a very good prognosis. Stage 3 starts localized seeding of the tumor, which has a moderate prognosis. Now stage D has a diffuse seeding, and stage E is the aggressive widespread stage of retinoblastoma.